Hey everybody, it's Adam Farkas. Welcome to another ODwire webinar. Thanks so much for making it out tonight. So interpreting retinal OCTs and introducing OCT angiography. So these are two really important and popular topics. And in fact, I was looking through our archives today. The interpretation of OCTs actually makes up our most popular series on ODwire. We actually have one OCT webinar that has been viewed over 600,000 times on ODwire. So our most popular piece of footage ever was one of those. And I'm sure tonight's lecture is going to be very similar to that in terms of popularity because this is a very hot topic. And we're going to go further by talking about OCT angiography as well. So if you haven't seen this technology work, this should be a great overview. And I just also want to remind you that this is part one, but this is a two-parter for you. And we're going to do the other part in November. And with that, let me introduce our speaker tonight. So we have Dr. Nathan Lighthizer, and I think you probably have heard him speak, if not here, in many other places. He's the Associate Dean as well as the Director of Continuing Education at the Oklahoma College of Optometry. And in 2014, he actually founded and he heads the Dry Eye Clinic at the College of Optometry as well. So he's a man that wears many hats, and if you read any optometric journal, gosh, I don't know, in the past 15 years, he's been all over them. So I couldn't be happier to have somebody out here like Dr. Lighthizer to take us through all of this tech and teach us all about OCT. So with that said, let me give him control of the system and then away we go.
All right, thanks, Adam. Appreciate it very much. Good evening, everybody. It's my absolute pleasure to be here. I want to thank Adam and CEwire, ODwire for having me. I want to thank Visionics for having me as well for this talk on retinal OCTs and introducing OCT angiography. Again, emphasize the part one. We're here tonight for part one, and we're going to build on tonight and come back on, I believe, November 9th. I think that's Wednesday, November 9th for the part two here in just a few weeks. So again, Nate Lighthizer, I'm a faculty member at the Oklahoma College of Optometry, where I've been there for, hard to believe, 13 years now and serving a variety of roles, as Adam said. So tonight we're going to talk on, mainly OCT angiography. We're going to start with OCT and kind of build up, looking at some OCTs, outer retina, what the main way that OCT angiography is being used for, but there's a variety of different things. So we're gonna go, what is OCTA? How does it work? What is normal? You really can't know what abnormal is until you know what normal is. So you gotta be comfortable going, okay, this is what it should look like. And now this is what it's looking like in our patient. It doesn't look normal. Well, what's going on? What is it in this particular case? So again, we're going to talk on that, and then we'll end with some case studies this evening over about 4 different cases, and we'll continue that 4 weeks from now on November 9th with part 2. So as Adam said, polling. If you've been to my lectures before, I like to poll the audience and keep it as interactive as we can. I obviously know that we are not in person tonight. We are virtual via online, but we can still do the polling that way as well. This is not required, so you don't have to do the polling, so don't feel like you have to do it, but it's encouraged. It's a fun way to kind of see what's the audience thinking. There are no individual answers. This is completely anonymous. Nobody will know what you put. I won't even know what you put, but again, it's a nice way to get a feel for going, oh, okay, most of the people are thinking A versus B versus C versus D. Again, no individual answers. It's completely anonymous. And again, it's not required, just encouraged to do this as we go throughout tonight. I'm going to ask you in the 4 cases. I'm going to say, okay, are you concerned? Are you not concerned, or just slightly concerned? And we're going to have you guys vote, and we'll see what the group is thinking in these 4 different cases. So that's how we're going to do the polling. And we are going to start off with a poll on slide number 1 here. Here's poll number 1, and I think Adam's going to launch this in just a second. And the question really is, do you have an OCT in your office? Yes, I do, or no, I don't. And we're going to give you, there we go. The screen should have went black for you, and then you've got a couple of choices there. And the polling is in progress. This is an interesting question. I've lectured on OCTs for the last 8 or 9 years, and I've asked this question for most of them, and it's been fun to see the responses. I tell you, 8, 9 years ago, it was probably about 30% did, 70% didn't, maybe 40% did, 60% didn't. It was more didn't than did And as we went through 2018, 19, 20, 21, now into late 2022, it's amazing to see where this percentage has went. Again, so do you have an OCT in your office? Yes, I do, or no, I don't. Adam, let's go ahead and see the results for poll number 1 and see what the percentages are. I'll be curious to see in this audience of about 200 plus docs.
Okay, so here we go. I'm going to close it, and hopefully it'll show it to everyone. If not, I can just verbally tell you. So it looks like 60% yes, 40% no.
Okay, so 60% yes, 40%. So we've kind of flipped those percentages from 7, 8, 9 years ago. So more and more ODs having OCTs in their practice. Let's go one more poll very quickly. I'll be curious to see this. One more poll, and this will be to poll number 2. I guess I have to advance it, don't I? Do you have OCTA in your practice? Do you have OCT angiography in your practice? Yes, I do, or no, I don't. Again, obviously the percentages are likely going to be much less. So let's go ahead and launch that. There we go. The percentages are going to be much less, I'm guessing, for this one compared to OCT, but let's see the exact percentages of OCT angiography. You know, OCT angiography is just a very unique test to be able to do, to get that quick OCT scan and image the vasculature that we can't see with the naked eye. When we're viewing the back of the eye with our 90 diopter lens, 78 diopter lens, whatever it is, to be able to see blood vessels when we can't see them, things like capillary dropout, enlargement of the foveolae vascular zone. Those will be 2 topics that we really emphasize 4 weeks from now on November 9th when we talk about diabetes. But we can't see enlargement of the foveolae vascular zone, capillary dropout with the naked eye. So OCTA just gives us a tremendous advantage in being able to visualize that. Let's go ahead and show the responses to this, or we can shut down the poll. And I'm going to guess it's going to be 5 to 10% say yes. But Adam, am I right or wrong?
So you would be shocked because we have a very high-tech audience here today. So 20% yes, 80% no.
There you go. So we go from 60% of OCTs down to 20% of OCTA. That is one of the highest percentages that I've seen with OCTA. So obviously a very progressive group that are practicing out there. So let's continue on. And you have to give me control back. There we go. Perfect. So we're going to start with just real quick. I think you need to talk on OCT, specifically in the outer retina, before we get into OCT angiography. So one of our kind of first cases here, you just show up a picture of a fundus photo, and obviously we've got extensive drusen in the posterior pole in this particular patient there. And the question is, when you see a patient like this, or you see a patient like this, and this was a 78-year-old female that's, again, got extensive drusen in the posterior pole. You can see geographic atrophy here. The question on our mind is this dry? Is this wet? More likely dry than wet, but looking for signs, has this patient converted from dry macular degeneration to wet macular degeneration? And OCT has been so valuable to be able to pick up fluid, to be able to pick up that choroidal neovascular membrane without having to have a fluorescein angiogram, or at least before the fluorescein angiogram. So again, here's another patient of mine. And again, you take a look here, and again, I'll just give you a couple of seconds to digest this macula. And in this patient in her 70s, are we dry? Are we wet? We're going to take a look. Do we see any blood? Do we see any hemorrhages? Do we see any edema, any elevations, any presence of maybe a choroidal neovascular membrane? Again, we could look at this with the naked eye back in the 70s and the 80s and the 90s and the 2000s, but OCT has just given us a beautiful way to pick up, is there fluid forming either subretinally or intraretinally? This looks to be dry. So my next question for you is, and take a look at these 4 photos, which OCT is most likely going to correlate with this fundus photo? So we're thinking this is dry macular degeneration. We don't think this is wet yet. Which of these OCTs, A, B, C, or D, which one of these most is showing you a likely picture of dry macular degeneration? So let's go ahead and open that poll again, and you can see 4 different OCTs.
Here we go. So the picture is going to disappear when I open it. So everyone take a good gander, and here we go. So, okay, and launch.
We've got four different retinal pictures there. And again, we think this is dry macular degeneration. And we're going to cover what dry macular degeneration looks like in an OCT, which I'm sure most of you know already. So we'll review that before we go into OCT angiography, but really trying to pick up subretinal fluid, intraretinal fluid. But here's the point I want you to remember as we transition from OCT in the discussion to OCT angiography. When we're using OCT, we're often waiting for fluid to leak into the retina. We're waiting for that choroidal neovascular membrane to leak the fluid. Well, what if they have a choroidal neovascular membrane that should not be there, but it's not leaking fluid yet? The OCT may not detect that intraretinal or subretinal fluid. So to me, the beauty of OCTA is to image it one step sooner, before it leaks fluid into the subretinal space or other spaces. Now we can image the choroidal neovascular membrane directly, which is hard to do with OCT. Not impossible, but hard to do with OCT. Certainly fluorescein has done that traditionally, but OCT angiography, the ability to image it one step sooner in macular degeneration. Let's go ahead and shut down the poll.
Okay.
And take a look. And which way are we leaning, Adam? A, B, C, or D?
So A is the winner with 44%, followed closely by B with 31%.
Okay. So again, most of you answering a clinical picture of macular degeneration. Yep. Is this dry? Is this wet? There we go. And you go back again. I think this is dry macular degeneration, and the OCT and A, the majority rules, that is dry macular degeneration. Clearly here you can see some subretinal fluid. We'll get to these OCTs in just a second. That would be subretinal fluid, and intraretinal fluid makes you highly suspicious for wet macular degeneration. OCT and C is going to be cystoid macular edema, or CME, and then the OCT and D is going to be central serous chorioretinopathy. So we've got 4 different conditions with those OCTs. This patient, there was their OCT here, and you can see this dry macular degeneration. We've got a bumpy outer retina, the RPE, yet we're not seeing any fluid at this point. Again, this OCT really appears to be a dry macular degeneration. So when you're looking at OCTs, again, not OCTA yet, but OCTs, we are looking at a picture that you look like here. This is, again, a bumpy outer retina, RPE. You can have a disruption of the photoreceptor integrity line, but again, no fluid is present at this point, either at the subretinal space or the intraretinal space. Again, dry macular degeneration looks very good here. I wouldn't be suspicious. And again, a classic picture of dry macular degeneration. What would you expect this patient's visual acuity to be? I would expect it to be reasonably good, probably somewhere between 20/20 and 20/30, maybe 20/40 at the most, but really I would probably expect 20/25 or 20/30. We've got a disrupted outer retina. That photoreceptor integrity line is kind of going up and down and up and down. RPE bumpy, but yet no fluid at this point. So I would call this dry macular degeneration. But I would still, if you're one of those 20% that has OCTA in their practice, I would be running an OCTA on this patient. Can I pick up a choroidal neovascular membrane one step before it leaks fluid? If we can prevent a membrane from leaking fluid into the retina, that is a win for that patient. So again, dry macular degeneration showing pigment epithelial detachments, or PEDs in this particular case, a big one, big couple of them on the bottom. And again, more pictures of dry macular degeneration right here. One other case, and again, a hint, it's not macular degeneration in this one. This was a patient in their late 60s. And you take a look in late 60s, we've got some pigmentary changes in the macula, as you can see right here in the right eye, and the back of the left eye looked similar as well. So okay, late 60s, we've got some pigment changes. Is this macular degeneration? Vision was between 20/25 and 20/30, so it's not terrible. We got a mild cataract, so maybe that's partially responsible for the 20/25 to 20/30 vision. So let's get an OCT. There's the OCT in the right eye and the OCT in the left eye. And this is more striking in the left eye compared to the right eye. I'll call your attention to kind of this spot right here. I'm going to show you another case of the same condition. Again, different patient, but same condition. And I haven't told you what this condition is yet. Again, a hint, it's not macular degeneration. Here's the same patient again, right eye. You can see this little substance, just a little bit of substance right here. There's the left eye, much more prominent in this particular patient. So here's a different patient, and you can see the left eye in this different patient here. And again, a hint, this is not macular degeneration, even though we've got some pigmentary changes. What does the OCT look like in this particular patient? Again, there's the fundus photo. What does the OCT look like? And there's the OCTs in both eyes. And again, I'll give you a couple of seconds to take a look at this. And clearly we've got some outer retinal disruption in both eyes, fairly symmetrical in this particular case. I like to show the 5-line raster here. Again, you can see that's just really highlights in this particular case. And you know what this kind of looks like? I always show this and say, you know what the shape of this looks like? It looks like central serous chorioretinopathy. There's an OCT of central serous chorioretinopathy, but notice in central serous we have clear fluid right here, so that's why the OCT image is black, versus in this particular case, we have got, there's some substance there. This is not optically empty or black on the OCT. There is some substance there. What is this OCT showing you? And again, this is a patient I saw way back when, and sent this to the retina specialist just to get a second opinion. I suspected adult vitelliform disease, and that's exactly what he confirmed was adult vitelliform disease. So if you ever see an OCT that looks like this, that is an OCT of a vitelliform lesion, which can be seen in obviously Best disease in juveniles. It's more common, at least we see it more commonly in adults as adult onset vitelliform disease. Fortunately, it tends to be much more mild, but there's the OCTs of a vitelliform lesion. In this case, it was an adult. So again, dry macular degeneration can cause some atrophy. You can see the atrophic changes as in this case. Notice your fairly normal retina on this left side here. And you take a look and we've got the, I believe you guys can see my pointer here. If we've got the RPE, and then we've got the photoreceptor integrity line, that thin white line right there. And then just above that's a faint line, that's the external limiting membrane, the outer nuclear layer, the outer plexiform layer, the inner nuclear layer, the inner plexiform layer, the ganglion cell layer, that white wedge right there. We know this is the nasal macula because of this wedge here being more prominent on the nasal side. So there's the nerve fiber layer, and finally the internal limiting membrane. So you can clearly see in this patient, look how the outer retina is there, and then completely gone. We've got complete atrophy in this area, and you can see a sinking in of these inner retinal layers right here in this particular case. So again, this was a significant atrophy, geographic atrophy in dry AMD. Here was a case of plaquenil toxicity. Again, we're at the level of the outer retina, and this is a patient I saw about 8-9 years ago, and you can see this significant retinal atrophy. Those of you that have OCTs, 60-65% of you, do you prefer your OCTs to be in color or black and white? And I would bet you prefer them to be in black and white. And here's the black and white. And again, you can clearly see on the nasal side in both eyes, outer retinal atrophy. You follow my cursor again, the photoreceptor integrity line is good. Why was this patient 20/20? Because the photoreceptor integrity line is intact underneath the fovea, but then you get over the nasal side and the outer retina completely falls apart here. The inner retina is sinking in. We are hyperfluorescing. The choroid is more noticeable. That's why this is glowing white. Why is that more prominent? Because you have less retinal layers, so more OCT signal is getting through. Again, complete outer retinal atrophy in a patient that had been on Plaquenil, a high dose for 21 years, and this was a case of Plaquenil toxicity affecting the nasal retina more so than the temporal retina. So again, shifting before we go to OCTA, you go from dry macular degeneration to wet macular degeneration. Your OCTs go from this, again, a dry macular degeneration, to something like this. And now we're seeing clear subretinal fluid. We are seeing intraretinal fluid. If you ever have a patient with macular degeneration and you are seeing fluid pockets like this, that is screaming towards you that we have likely wet macular degeneration in that particular case there. So here was a case. My wife actually saw this case. My wife is an OD, practices here at the college as well. And I remember I was traveling somewhere. I was speaking somewhere, and she texted me this picture and she said, what do you think is going on in this mid 70-year-old females? So mid 70-year-old female, she texted me this picture. What do you think's going on? I said, I think they're bleeding in the macula. She said, yeah, you're a smart aleck. Thanks, hon. But I said, yeah, that's a significant hemorrhage in the macula. What's the other eye look like? And the other eye, again, in this patient in their mid 70s, had some drusen. Let's get an OCT, and you take a look at the OCT, and we can see a clear RPE detachment. Look at that RPE right there. The RPE is detached. We have a hemorrhagic RPE detachment in wet macular degeneration. So OCT, very, very valuable to show us things like this that we couldn't see before. So wet macular degeneration. But again, I'll leave you with, before we get to OCT angiography, this patient could have a small choroidal neovascular membrane. Again, this looks dry, and they could be converting to wet macular degeneration. They could be growing a choroidal neovascular membrane. It's not leaking fluid yet, and it potentially still looks like this. We got to wait for it to leak fluid before we can see this. So let's image this one step sooner, before it's leaking fluid into the subretinal space and the intraretinal space as well. And that's where OCT angiography, the next chapter in posterior segment imaging, really has a nice place in imaging these one step sooner. So OCT angiography, it's amazing how OCT has evolved over the course of the last 15 to 20 years. I mean, I went to school from 2005 to 2009 at Pacific University. I was trained on the Stratus OCT back when there was only one company that had OCT, and it was truly state-of-the-art, revolutionary at that time, the time domain OCT. And very quickly after that, it went into spectral domain, a variety of companies, and just tremendous technology. So from time domain to spectral domain, and now OCT angiography, the ability to image that retinal microvasculature without a dye injection, which is certainly very beneficial. So, you know, the new approach to visualizing blood flow. If I asked you guys live in person, I said, how have we traditionally visualized blood flow? And the answer is a fluorescein angiogram. You know, that's how we saw, what does the capillary network look like? Is there any capillary dropout? Is there enlargement of the fovea vascular zone? Is there any abnormal NVE, NVI, NVD? Is there any neovascularization? Again, the patient had to get an injection into the arm, fluorescein angiogram, again, a little bit more invasive. And it took some time to be able to do that. Now, to be able to reduce the patient burden, more frequent imaging. I mean, you can get this image almost as quickly as an OCT. It takes just a matter of seconds, much faster than a dye-based procedure, and it just images those different retinal layers. So how does this work? OCT angio, you know, how does it image and give you these nice pictures of the macular, you know, the capillary network? How do we do that? Well, how does OCT angiography work? Well, it provides a snapshot of red blood cell motion. Think of red blood cells, and taking sequential B scans. They just a series of quick OCTs happen so quickly. It's just over a matter of seconds. And the only thing that should move from split second to split second to split second to split second are those red blood cells. So the software, the computer, it knows that the only thing, when it detects movement, that must be moving inside a blood vessel, and therefore that is a blood vessel, that's blood, and it can map out where those blood vessels are at. So it uses red blood cell motion to give us a high resolution image of the microcirculation, the capillary beds, and to better delineate capillary non-perfusion. Again, FA, still warranted. I want to make a clear message tonight that just because you have OCTA does not mean that you will never need an FA, a fluorescein angiogram. You may still need a fluorescein angiogram. There's various advantages and disadvantages of both, but certainly OCT has a prominent place. So uses motion contrast, like we just said, motion contrast, the difference in two OCT-B scans, and the flow is the difference. It's the difference in signal between those sequential B scans as you're quickly getting that image in that patient. So, and it gives you something called en-face imaging. And I want to spend just a couple of minutes on en-face OCTs, because you can do this with both OCT and you can do this with OCTA as well. So what is en-face imaging? Well, again, if I was in person, I'd show you kind of a notepad or a book of sticky notes, and I'd go, okay, you're looking at the first sticky note, let's peel that away. and then you're looking at a little bit deeper of a sticky note, then peel that one away. Now you're looking at it even a little bit deeper of the sticky notes, peel that away. So you're going layer by layer by layer by layer through that retina, and that's what en-face imaging does, and that's how OCT angiography works. You go layer by layer by layer by layer. We start in the superficial capillary plexus. Where is that? In between the internal limiting membrane and the inner plexiform layer. We've got the superficial capillary plexus, the superficial retinal capillaries. And again, we can't see most of these with the naked eye, and you can easily visualize a nice capillary bed, foveolae vascular zone right in the center there. Looks great. Let's peel that away and go one step deeper from the superficial plexus down to the deep plexus. That's in between your inner nuclear layer and your outer plexiform layer. Okay, so that's looking well. You peel that away and you go one step deeper into the outer retina. This is in between the basement membrane of the RPE and the outer nuclear layer. Of note, there are no blood vessels in this area, so that's why you should image this dark. There should be nothing there, which is what you're supposed to see in normal. We'll go over that, what normal is, in just a second. But then you peel that away, and one step deeper, now you're into the choriocapillaris, which is a densely vascular sponge. And you can see that kind of densely vascular sponge here. So layer by layer by layer by layer, that's the en-face imaging. Let me show you a case that utilizes en-face imaging from OCT, not OCTA, but OCT. This is a 60-year-old female, referred in from a retina specialist for electrophysiology testing, actually. Retina specialist sent this patient in and said, I can't figure out why this patient is 20/60 in this right eye. I'm evaluating the retina. The retina, by my judgment, is not poor enough to cause 20/60 vision. The retina looks like a 20/25 to 20/30 retina, but yet this patient is 20/60. The retina specialist was considering an MRI to try to figure out why is the vision down in this right eye. Again, 60-year-old female. And you take a look at the OCTs. And again, I'll give you a couple of seconds to digest these OCTs. I'm guessing if I said, just based on this slide, just based on what you're looking at, what is the likely visual acuity of this patient in the right eye and the left eye? I'm guessing most of you would say between 20/20 and 20/30. These are, again, there's a small epiretinal membrane in both eyes, but it's not really distorting the retina for the most part at this point. There's no significant, thickening of the retina. The photoreceptor integrity line looks relatively good. So I think most of us would say, hey, I could see this 20/25, give or take a line either way, but yet she's 20/60 in the right eye, 20/60 in the right eye. And that's why the retina specialist is considering an MRI to try to figure out, is there something neurologic going on? Here's the raster scans, and you take a look at the raster scans, and again, it confirms our internal limiting, our epiretinal membrane right there. We've got a mild epiretinal membrane, slight loss of the foveal depression, but no major thickening. Again, I would call this a mild ERM in both eyes, not responsible for 20/60 vision. But look what happens when you go to the en-face OCT, to be able to show it slice by slice by slice. In this case, it's the internal limiting membrane. It's the inner plexiform layer. It's the RPE layer. And then lastly, look at the choriocapillaris. You can see those deep choroidal vessels right there. In this case, as you all know, an epiretinal membrane is a disorder of the internal limiting membrane. Look at how you can image the widespread diffuse nature of this epiretinal membrane, where it looks reasonably mild in this particular OCT scan. It's shown to be much larger and much more prominent in this OCT scan. Again, this is not OCT angiography. This is en-face imaging. And again, you show this to the patient and, now I can understand why my vision's down, maybe a little bit distorted. A picture is worth 1,000 words, is it not? To be able to show them this and go, this is a big wrinkle that you have in the back of your eye, and this is what's causing your vision to be down in the right eye more than the left eye. She actually had a mild membrane in this left eye as well. Retina specialist did a membrane peel based on these scans, and her vision returned to about 20/30 in that right eye. So utilize different ways to look at the OCT, from just your regular, retina map to your raster scans. This is a 21-line raster, to your en-face imaging as well. Just a nice way that you can image that. So that's how OCTA works. Okay, it has en-face imaging. You can see the superficial capillary plexus, the deep capillary plexus, the outer retina, and the choriocapillaris. So again, this is what it looks like. We're going to go through normal here right now. So you can't know what abnormal is until you know what normal is. So let's take a look at normal. This is a very, very normal OCT angiography of a healthy 25-year-old optometry student. So 25-year-old optometry student. And you'll notice when you take a look at this, I'm going to call your attention that we have no numbers here. This is qualitative data. It's given us just wow pictures, especially these two on the left, but just wow pictures of imaging that capillary network. But at the start of having this technology, it's hard to believe we've had this technology for 6 years now, actually 6+ years. But we didn't have any numbers at the start. I like quantitative data as well, and I bet you guys do in your glaucoma patients. Even when you're looking at the macula, you're looking at the numbers of the macular thickness. So when we started this, again, 6-7 years ago, we had this fascinating picture, but it's qualitative only. There's no numbers. So again, on the left here, we're giving slice, 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 slice through the superficial capillary plexus. Notice that capillary network. You can clearly see the big vessels, but now we can see those smaller capillaries as well. We can image the foveal avascular zone, this circle right here. That will be a highlight at our next webinar 4 weeks from now. But again, a nice normal, this is what you'd expect to be for the superficial capillary plexus. You go a layer deeper to the deeper capillary plexus. And again, you can see these nice capillaries here. We're not seeing any capillary dropout. We're not seeing an enlargement of the foveal avascular zone. This looks perfect, nice and healthy. And then we get a step deeper and we're in that RPE, or that outer retina, which should be avascular. And that's why we're seeing it nice and dark and no vessels there. And lastly, the choriocapillaris, that vascular sponge right there as well. So again, very, very normal, layer by layer by layer by layer. And then again, you can manipulate the software to say, okay, let's blow up each image. Here is, again, B scans on the bottom, OCT B scans, I should say, the OCT angiogram of the superficial capillary plexus on the left. And then there's the deep capillary plexus. And then there is the outer retina, again, dark. And again, there's the choriocapillaris. So last point that I'm going to mention, this is very important, really a key take home. What am I looking for in different disease? You know, we're about to go through OCTA in our clinic. What are the indications? Well, there's a lot of indications for OCT angiography. I would say the flashiest, kind of fanciest, the biggest wow factor is with macular degeneration. That's what we're going to focus on for our last 10 to 12 minutes in this webinar is macular degeneration. Again, it's flashy, it's fancy, it's like, wow, it's to be able to image that. But you can use this in diabetics. That will be the emphasis on webinar number 2. Vein occlusions, retinal vascular disease, even glaucoma patients as well. So there's a lot of indications. Which images do I look for in which retinal conditions? Well, here's your take-home point. The two on the left, the superficial capillary plexus and the deep capillary plexus, those are retinal capillaries. Those are retinal capillaries. So I am evaluating and looking at those in conditions of retinal vascular disease. What's your main retinal vascular disease? Diabetic retinopathy. So diabetes and diabetic retinopathy, vein occlusions, artery occlusions, things that affect the retinal capillaries. I'm going to be looking at the 2 scans on the left, and I'm going to be looking for, are blood vessels dropping out? Are blood vessels dying off? Do we have capillary dropout? So I'm looking for the presence of abnormal vessel dropout. Those 2 on the left, again, for retinal conditions. The 2 on the right, where we normally shouldn't see any structural membranes, that's where I'm evaluating for choroidal neovascular membrane. So conditions like macular degeneration, pathological myopia, histoplasmosis, angioid streaks, trauma, except if you're looking for the presence going, I'm trying to figure out if this patient has a CNVM, a choroidal neovascular membrane, you're going to look at the 2 on the right. So 2 on the left for diabetes, diabetic retinopathy, retinal vascular disease, vein occlusions, and the 2 on the right for macular degeneration, histoplasmosis, basically to pick up the presence of an abnormal choroidal neovascular membrane. Notice that the 2 on the left, we're looking for blood vessels that are abnormally dropping out. And the 2 on the right, we're looking for blood vessels that are abnormally appearing. that are presenting themselves because we don't normally want a CNVM. So again, let's go into the indications in our clinic and go through some cases. You know, isn't this really the big question when it comes to us as optometrists, when we're managing retina? I always make the point, you know, generally speaking, when a patient comes into your office, I had one just yesterday morning, he came in with a red left eye. He's got a red left eye. We put some staining, evaluated. Guess what he had? He had a big dendrite on the inferior part of his cornea, and we diagnosed herpes simplex infectious epithelial keratitis, and I put him on an antiviral, okay? My point is we treated that. When it comes to cornea, ocular surface, treating a uveitis, treating a red eye, treating a conjunctivitis, treating dry eye, we are pulling the trigger on treatment, whether it's the eye drops, whether it's the orals. What's our job often in retina? When it comes to macular degeneration, when it comes to vein occlusions, when it comes to, you know, things like that, what is our job? It's often we're making the decision, should I continue to watch this, which we often do, or should I send this out? Should I send this to our fine ophthalmology colleagues, our retina specialists? That's in big part our decision when we're pulling the trigger is, should I refer or should I watch this? Let's go through some case studies. So this is case number one. This was a 71-year-old Native American female. And I saw this patient, hard to believe, about 6 years ago, and referred in for a macular OCT. Do we have macular edema? Do we have central serous? Do we have a CNVM? This patient has a history of dry macular degeneration. It's fairly mild. And notice we've got a decrease in vision in that left eye, 20/70 in that left eye. We've got an Amsler grid defect in that left eye. So we are suspicious, no doubt about it, with vision down to the level of 20/70. Our satellite clinic didn't have OCT in it at the time, so they sent her in for an OCT. Let's figure out what's going on. Something we think is going on in the macula, but let's get an OCT. Amsler grid, again, suspicious in that left eye. There's the back of both eyes. And you take a look at this, and I'll give you a couple of seconds to digest. Again, right eye is 20/20, left eye is 20/70. We certainly have got some macular changes in that left eye that call our attention. Let's get an OCT. Here was the OCT on phos in the left eye, and you'll notice, again, I'll call your attention in this area, and you can see we've got some disruption on the OCT. So there's your OCT. So I'm going to ask you with our polling here, again, very quickly going back, in this 71-year-old female, left eye, there's the fundus photo. OCT looks like this. Take a close look of that OCT in the macula. And my question for you, we're going to poll the audience with poll number 4 here, is are you concerned? Are you slightly concerned, or are you not concerned at this point in time? And Adam, let's open up that polling.
All right, so poll number 4, here we go.
All right, so again, 71-year-old female, you saw the back of the eye, you saw the OCT. I'm going to show you the OCTA in just a second, but based on the data that I've given you in this 71-year-old female, are you concerned? Are you slightly concerned? Or are you not concerned at this point in time? We'll give you a couple of seconds to answer this. All right, let's go ahead and shut that down, Adam, and you can let us know what % are concerned versus slightly concerned versus not concerned.
All right, so 70% of people are concerned, 26% slightly concerned, and 3% not concerned.
And just as I suspected, we are strongly leaning towards concern. Again, 96% of you are concerned or slightly concerned. I would completely agree in that particular case. You know, if you told me, if you said, Nate, you know, I don't even know if you need OCTA in this particular case, I would go, you're probably right on that. I don't disagree with you, because we've got a patient with decreased vision, metamorphopsia in the Amsler grid, and you can clearly see we've got a significant outer retinal disruption, RPE disruption, with some fluid in the outer retina as well. I would be highly suspicious even without the OCTA. But what's really cool is you take a look and you image this, and this is at the level of the choriocapillaris, and you can look at this great big old choroidal neovascular membrane right there. So to be able to image that, to be able to show that to the patient, a picture is truly worth 1,000 words. Very powerful. This is leaking fluid in the back of your eye, and we need to treat this so it doesn't continue to leak fluid and cause damage. Again, If you said, I don't think you even needed the OCT, I'd have been suspicious even without it. I was suspicious without it as well, but really just shows you how well that images it very well. So let's go ahead and let me show you. There we go. Again, there's normal, and we showed you what abnormal is. So case number 2, this is referred in for OCT due to vision changes. This is a 63-year-old male. We were 20/20 in the right eye, 20/40 in the left eye, so vision down just a little bit in the left eye. There's the 20/20 eye. Okay, 63-year-old patient. I think it was a male patient. 63-year-old male. Yep, back of the right eye, 20/20. Back of the left eye, 20/40 in this particular case. Let me show you the OCTs. There are the OCTs in both eyes. Again, back of the right eye, back of the left eye. Definitely a different picture than case number 1, where case number 1, we were highly suspicious just based on the OCTs. But it's going to be the same question for poll number 5 based on the OCTs that you see here. And based on the fundus photos, right eye, left eye, as you can see, right eye there, left eye here, OCTs, 20/20 in the right eye, 20/40 in the left eye. Let's go ahead and launch poll number 5. Are you concerned? Are you slightly concerned? Or are you not concerned in this 63-year-old male patient? So again, last one, case number 1, we were 70% concerned, 26% slightly concerned, and 4% or 3% not concerned. So we were heavily leaning towards the concerned side. We'll see what you guys are thinking for case number 2. All right, case number 2, Adam, for time purposes, let's go ahead and close case number 2 and our percentages. I'm guessing they're a little different.
They are 28% concerned, 68% slightly concerned, and 5% non-concerned.
Adam, never wrong to be slightly concerned, right? Right on the fence. We could go either way on that. So that's exactly where I was as well on this. I think, this is one of those, should I watch? Should I not? Vision's down a couple of lines in one eye. This is the beauty of having OCT angiography. And you take a look in this particular case. This was the OCT angiogram in the right eye. And note, again, with macular degeneration, I'm focusing my attention on these 2 on the right, and we can pick up the presence of a small choroidal neovascular membrane at this level and at this level. It has not leaked fluid yet at this point. Actually, the left eye, which was the 20/40 eye, is that a subtle little change right there? Hard to see, right in the center there. But in your decision-making process, should I hold on to this and monitor, or should I refer? I think this takes you from slightly concerned to maybe a little bit more concerned, and let's get a second opinion with that retina specialist in this particular case. Case number 3, 71-year-old female. Referred in again for OCT, glaucoma. We've got macular degeneration. Vision's 20/25 minus on the referring exam. Now it's 20/30 plus, 20/40 plus. So again, vision's down a line or 2. There's the back of the right eye. And again, 20/30 to 20/40 in both eyes, back of the left eye, back of the right eye, back of the left eye. Again, we've got pigment changes in this, again, 71-year-old female. We've got pigment changes in the back of the right eye, pigment changes in the back of the left eye. There's the OCTs, got the retina map OCTs. Give you a couple of seconds to digest the retina map OCTs, seeing a lot of thinning across these retina maps, a lot of thinning. There is the retina map in the right eye, there's that, and there's the 5-line or 21-line rasters in both eyes. So, excuse me, right eye on the top, left eye on the bottom, okay? Focus in on that right eye. Okay, we've got a little vitreomacular adhesion there. I'll give you a couple of seconds to take a look at this. So in this 71-year-old patient, there's the OCTs. Are you concerned? Are you slightly concerned? Are you not concerned at this point in time? Adam, let's go ahead and launch the polls. Again, you guys saw the photos. You saw the OCTs. Vision, again, 20/25 minus on the referring exam, 20/30 plus, 20/40 plus on the exam when I saw this patient. Again, we're really determining, is this dry macular degeneration? Is this wet macular degeneration? Adam, let's go ahead and close the polling. And what's our breakdown?
So it's 63% concerned, 33% slightly concerned, and 5% non-concerned.
And I would agree with that. You know, you take a look, and I'm a bit concerned about this OCT here. You take a look at, God, we've got some elevation here. You know, is this a membrane growing here? But notice we don't have any fluid. There's no subretinal fluid. There's no intraretinal fluid at this point. And again, OCTA just did a beautiful job. And you take a look at this, and you can see clearly, look at the membrane that is imaged there, a choroidal neovascular membrane at the level of the choriocapillaris, broken through and into the outer retina as well there. Again, let's get to this to the retina specialist sooner rather than later. So a third of you were slightly concerned and maybe observed this, and I think that's a very reasonable based on OCT. Watch this closely. Maybe you're in a remote location. But at this point, I think, you know, you see this and going, man, we need to get to retina sooner rather than later to get this treated and the CNVM to hopefully go away very quickly at that point. So, you know, I want to make, there's our nice image of that CNVM in the outer retina right there. You know, I want to make the point, here's a different patient. You know, I've went through 3 cases and they've had a CNVM and a CNVM and a CNVM. You know, more often than not, the majority of the time when we're scanning patients with macular degeneration, it comes back something, you know, like this. And you take a look, what I'm meaning to say is more often than not, there's not a CNVM there than there is a CNVM. So don't let those first 3 cases fool you. This is, to me, the biggest utility of OCTA is you look at this and, okay, we've got a patient with clear outer retinal disturbance. We've got some drusen there. There doesn't appear to be any fluid. I need one more level of confidence, one more layer of confidence that there's nothing going on here. And you'll notice there's no blood vessels here for the most, there's really nothing here at all. And this has given me a level of confidence going, okay, there's no CNVMs at this point in time. There's no fluid in the retina. I feel confident and comfortable. You know, I'll see this patient back in 6 months and we'll follow this closely. Anything changes there. So it really gives you that next level of confidence. So I'm going to skip case number 4 for time purposes. On this one, just imaged a subtle, another choroidal neovascular membrane in this patient with dry converting to wet macular degeneration. So that's macular degeneration. I think we covered that in pretty good depth. We're going to get to diabetes and retinal vascular disease in part 2. Last thing I'm going to mention is in glaucoma patients. You know, I do really believe that OCTA, while still in its infancy, when it comes to utilization in glaucoma, we're still learning about this. We're still figuring this out, imaging the vasculature around the optic nerve. You know, chicken or egg, what comes first? Does the retinal nerve fiber layer thin first? Does the peripapillary vessel density thin first? I really think down the road, and this may be very soon down the road, we're going to be seeing printouts. We're going to be utilizing printouts like this, where you've got what we're all used to, that retinal nerve fiber layer on the left, and then vessel density around the nerve on the right, and looking for signs of retinal capillary density around the nerve. Is it thinning around the nerve? Or just like we're watching for thinning of the RNFL and thinning of the ganglion cells, we'll be looking for thinning of those peripapillary vessels around the nerve. So again, we're learning more and more on that, and I think it's going to have a major role down the road when it comes to glaucoma. Again, we'll get to diabetes next time. With that, Adam, I think I'm right at time. I'm going to kick it back to you and open it up for some Q&A.
All right. Well, thank you so much, Nate. That was great. And you actually were right on time. I'm very impressed. So, you know, we have time for questions, maybe a few more minutes worth. But if you want to ask a question, feel free. There's a box on the right side of the screen that says questions. Feel free to type them in there. If we don't get to your questions, remember, this archive will be posted on ODwire. You can always ask questions there, and we can continue the conversation online. So let me pop open the question box here and get this going. And okay, so question here, and I'll sort of take the questions as they come in and pass them on. So question here, how do you tell on an OCT whether dark space in a retina is just fluid versus just a space? As in, are all dark cystic spaces fluid or just spaces seen in the RM? How do you differentiate?
Yeah, that's a good question, and it really comes down to what is the pathophysiology causing the dark space? What's the history behind it? If your patient had cataract surgery 6 weeks ago and you're seeing multiple cystic spaces, with a mild epiretinal membrane, just based on the history of the cataract surgery 6 weeks ago. That history is dictating that that patient likely has post-cataract surgery CME, Irvine gas syndrome. So the history of cataract surgery and the multiple cysts in the central part of the retina, location, would indicate that those black spots are likely fluid filled. You take the flip side, and you've got a patient with an epiretinal membrane, and that's all they have. There's no history of diabetes. There's no history of recent cataract surgery, and they've got an epiretinal membrane that's decently significant, and you're seeing those black spaces. I would then say that's likely tractional in nature. That's likely not fluid leaking or cystic fluid leaking. So the clinical picture, the ERM, not fluid fill, that's not going to cause fluid leaking. It's just going to kind of separate those layers, and that can cause a black spot. So what's causing it is ultimately going to help me know whether that black space is fluid filled or whether it's non-fluid filled.
Got it. Question here about image acquisition. How much longer does it take to do an OCTA versus the traditional OCT?
Yeah, it's very, very quick acquisition. Again, OCT probably takes less than a second, depending on which scan you do, whether it's the retina map, whether it's the raster scan, but we're talking a period of a half second to 2 seconds for OCT. For OCT angiography, I would say it's between 2 and 3 seconds, somewhere in there. I mean, you think 1001, 1002, 1003, yeah, between 2 and 4 seconds is what I would say. So this is not a 10-second scan. It's not a 20-second scan. You're talking just a second or 2 or 3 more than your normal OCT. So very quickly, under 5 seconds.
Right. And I guess the follow-up question is, how often do you have to repeat the OCTA scan versus a traditional OCT just because the patient moved or the machine couldn't pick it up properly?
Yeah, so there's tracking on there. So you can put tracking on there that says, okay, I mean, the software is so sophisticated now that if the patient moves their eyes, it will stop scanning until they refixate and then start scanning again. So do you have to rescan? Occasionally you do, but that software that you have for the tracking and the gaze stabilizing, that really helps you get good quality scans. Now, there's a double-edged sword to that. I've had some patients that their fixation is so poor that I had to turn the gaze tracking off because I would just never acquire the scan because they just can't look in one direction, and I can force the scan to be acquired. Now, the downside is it may not be in the exact same spot. I may have to just kind of take it with a grain of salt on that. So I don't have to repeat it a whole lot because of the software that's now in there with that gaze tracking.
Right. Question here about indications for an OCTA. I guess, the technology, as you mentioned, has been around for, I guess, 5 or 6 years now. Are the indications where you're ordering a scan, are they increasing over time?
I think they are, yeah. We're utilizing this more and more. Again, the first, we started with macular degeneration, really helping us differentiate between dry and wet. And then we'll talk on diabetes. So we started with macular degeneration. And diabetes, we started adding that in there. And again, we're just starting to scratch the surface of glaucoma. There's conditions called retinal telangiectasia that can help you dictate, do they have idiopathic juxtafoveal retinal telangiectasia, even central serous chorioretinopathy. Most of us think of central serous as a relatively benign resolving condition, and it usually is. But there's case reports there now, I should say there's studies out there now that indicate 15 to 20% of your recurrent central serous as a choroidal neovascular membrane. So the more you have the technology and the more you figured out, there's a condition right there, central serous chorioretinopathy, where we wouldn't have thought of using an OCTA 6, 7, 8 years ago. And now we get that in those patients. So more and more indications as we gain more experience with the device.
Right. And interesting question here, I guess another practice management type of question. When you refer out, do you always include the scans, the OCTA scans?
The answer is yes. When I send this out, I include the OCTA scans. I want the doctor, whoever I'm referring to know what I was thinking. This is why I'm concerned. And they may say, yeah, I'm still going to run a fluorescein and things like that. But yes, I include the scans that help to dictate my decision to refer.
Right. And actually, that's a really good question that I didn't really think about. In the world of ophthalmology, how frequently do they actually just rerun a fluorescein scan? They're just like, oh, to heck with it, let me use fluorescein. Are they actually using this in ophthalmology as well, more and more? The
So
OCTA tech.
it's being adopted in ophthalmology as well. I mean, our retina specialists still love their fluorescein angiograms. They're still going to utilize a lot of fluorescein angiograms, but we are seeing an uptick in the utilization of OCTA as well. Yes.
Right. And question, just to review, what were you looking for again that would indicate a CNVM in the OCTA? So I think you mentioned that early on.
Can I go back to show
Yep.
some? So what am I looking for to look for a CNVM? Again, I am looking for the presence. I'm looking for something like this. Again, in this scan, in this patient, I can't remember if this patient was diabetic or not, but we're going to really focus on the 2 scans on the left 4 weeks from now when we're talking about capillary dropout and we're talking about retinal vascular disease. It's in the name. Choroidal neovascular membrane is not a retinal vascular disease. It's in the choroid. It's a choroidal neovascular membrane. So whereas in diabetes and retinal vascular disease, we focus on these 2 on the left, it's these 2 scans on the right is where I'm really looking for the presence of an abnormal vessel. Is there something growing here that shouldn't be growing there? And that is a sign of your choroidal neovascular membrane. So I'm looking for the presence of abnormal vessels, vessels that shouldn't be there in these 2 scans on the right.
Yep. And I've got a comment here more than a question talking about artificial intelligence. And I think I saw a paper actually that just came out recently, discussing the ability of machines to take the outputs of OCT and OCTA and start to make predictions. So there's more of a comment there. I don't know if the units are doing it themselves at this point, or if this is something that's just being researched right now.
I believe it's just being researched right now.
Yep. So something to look forward to in the future.
Yep.
For sure. Okay, great. So we're actually right back up at the top of the hour. So I think we're going to have to hold the rest of the questions here, but I'll take all the remaining ones that I got here and I'll post them on ODwire, of course, with the archive. So, we'll make sure that the conversation will definitely continue online. And I also want to remind everyone, you're going to get a follow-up email from me, again, reminding everybody about part 2 of this, which is going to be coming up in November. So we'll have the date and links and so forth for you. And there's also a survey, by the way, in the email that you'll be receiving. Feel free to go fill out that survey if you can. Again, we're offering a little Starbucks incentive for the first few people that fill it out, so you might want to jump on it before we tell the rest of ODwire. So Nate, thanks again for doing this, and I'm really looking forward to the next part. I know we're going to do a pretty deep dive on diabetes. That should be fun, and we're all going to learn a lot. So again, thanks everyone for being here tonight, and I guess I'll see everyone online.
Thanks everybody. Enjoy your evening.